The human nervous system is designed to alert us to tissue damage. But in severe, late-stage illness, these pain signals can overwhelm every pharmacological barrier clinicians place in their path. Consider a 46-year-old woman with recurrent rectal cancer that has metastasized to her lungs and pelvic bones. This chart tracks her medication. To control her pelvic pain, her care team escalated her opioid intake until it reached a morphine-equivalent daily dose of 900 milligrams per day. Even at this level, she experienced no relief. The medical team layered on advanced adjunct therapies. They deployed localized radiotherapy. They administered epidural nerve blocks. They started continuous intravenous ketamine. The pain line remained at its maximum. Despite these symptom-specific interventions, the patient continued to rate her pelvic pain at a 10 out of 10 whenever she moved. At this stage, her Karnofsky performance status had dropped to 30. She was bedbound, severely disabled, and enduring continuous distress. This clinical state defines the refractory symptom, a symptom that cannot be controlled, even when all available expertise and aggressive treatments have been exhausted. When standard analgesia fails, the clinical strategy shifts. To relieve the suffering, physicians must move beyond targeting pain receptors and begin intervening on the patient's level of consciousness. The American Medical Association's Code of Medical Ethics, the framework governing end-of-life decision-making. The code requires physicians to elicit patient goals and identify a surrogate decision-maker early in the course of care, before a crisis occurs. This diagram illustrates a foundational axiom in the AMA code. There is no ethical difference between withholding an intervention and withdrawing one. The ethical appropriateness of withdrawing a treatment is determined by whether the intervention still serves the patient's goals of care or desired quality of life. Even if life-sustaining treatment is withdrawn, the physician's duty to provide aggressive palliative care and symptom management remains. The ethical permission to allow death by removing ineffective treatments provides the baseline logic required for the more complex clinical tool, palliative sedation. Modulating consciousness creates professional anxiety. Clinicians have long debated whether administering heavy sedatives near the end of life constitutes a form of slow euthanasia. This data visualization of Flemish death certificates reveals the source of that anxiety. While 9.6% of physicians categorized their final action as palliative sedation, in over 21% of those cases, the clinician harbored an explicit intent to shorten the patient's life. This statistical overlap threatens the ethical legitimacy of palliative medicine. When life-ending practices are mislabeled as palliative sedation, it blurs the precise lines of professional intent. To parse the ethics of an action that causes both a desired outcome and an anticipated harm, ethicists rely on the principle of double effect. This flowchart breaks down the 4 mandatory requirements of the principle of double effect. First, the act itself is not unethical. Second, only the good effect is intended. Third, the good effect is not achieved by means of the bad effect. And fourth, there is a proportionately serious reason to act. Applied clinically, this distinguishes palliative sedation from euthanasia.
In palliative sedation, the intent is to relieve suffering through sedation. In euthanasia, the intent is to end the patient's life. For the sedation to meet the standard of proportionality, the dosage is limited to the depth necessary to relieve the patient's specific distress. The ethical validity of the procedure rests on the clinician's documented intent to palliate symptoms rather than terminate the patient. Returning to our 46-year-old oncology patient, her refractory pain triggers the consideration for continuous sedation. But physical pain alone is insufficient. The patient must also meet strict prognostic criteria. Death must be expected within 1 to 2 weeks. The medical record must include a confirmed do not attempt resuscitation order and an interdisciplinary assessment, including psychological and spiritual consults to address potential existential distress. The team must also make a documented decision regarding artificial nutrition and hydration during the sedation. These fluids are typically discontinued. At this stage of systemic shutdown, forced hydration rarely contributes to relief and can increase complications like edema and bronchial secretions. For the sedation itself, clinicians use targeted agents like midazolam or propofol. Crucially, the analgesic doses the patient was receiving must be continued to ensure the pain remains treated while the patient is unconscious. These rigorous preconditions form a clinical envelope, protecting the patient from both inadequate symptom management and ethical boundary crossing. In the case of the 46-year-old oncology patient, the medical team did not immediately initiate continuous, irreversible sedation. Instead, they utilized respite sedation, a transient pause used to provide relief before considering further trials of therapy. The specific goal of this approach is to lower awareness temporarily, then return the patient to a pre-treatment level of consciousness. The team administered intermittent sedation at night to allow for restorative rest. This graph tracks the result. After holding the sedation each morning, the patient awake, and her pain dropped to a 3 out of 10. The severe distress was broken. She lived for 4 additional months, remaining conscious and comfortable during the day before her illness claimed her life. This case illustrates how modulating a patient's consciousness can function as a titratable medical tool. It serves as an intervention scaled to the degree of suffering, rather than a mechanism for hastening death. The clinical pathway follows a specific sequence: identify refractory symptoms, satisfy the prognostic criteria, and apply the principle of double effect. Under the AMA guidelines, withdrawing an ineffective intervention carries the same ethical weight as choosing not to start it. What remains is the clinician's duty of non-abandonment. When standard pharmacological tools fail, the physician must stay present with the patient's suffering and offer a proportionate response. When applied within these parameters, palliative sedation fulfills the physician's commitment to prioritize the patient's welfare and the covenant of trust that defines the medical relationship. By adhering to these ethical guardrails, clinicians fulfill their mandate to prevent suffering without compromising the foundational principles of medicine.